times that, that's what choroidal capillaries do. They leak. Retinal vessels do not leak, but choriocapillaries do. So they're going to do the same thing as they do usually, which is, leak fluid, blood, lipid, protein, all that stuff that leaks out of the vessels. And this, of course, is going to disturb the retinal function. The retina likes to stay dry. And with this, you get a healing response from the retinal pigment epithelium, which can transform itself into fibroblasts and then try to suffocate these vessels. And this fibrosis, when it happens in the fovea, of course, it's going to disturb the central vision, and you get loss of central vision. So the CNV is really the growth of these vessels, and the scars that you get out of it is a result of a wound healing response to injury of the choriocapillaries, the Brooks membrane or RPE. And therefore, any pathology that can affect any of those structures, that can affect the choriocapillaries, the Brooks membrane, or the RPE, can lead to choroidal neovascularization. And the list is very, very long. So you have the injury by the CNV cells, and this creates, ingrowth of inflammatory cells and a trauma to this area. And what controls the growth is actually a balance between the angiogenic factors and the anti-angiogenic factors, being VEGF. Now, VEGF is now known that is correlated with the development of CNV. It is found in pathological specimens of CNV, and its overexpression induces CNV. VEGF is expressed and produced by the retinal pigment epithelial cells, and the VEGF binds to the endothelial cells receptors, and what it does, it increases the permeability of these cells. It causes these cells also to proliferate, and it helps in them also migrate. So the CNV derives from both angiogenesis, which is developing neovessels from pre-existing vessels, but also vasculogenesis, where new vessels grow out of nowhere, out of original choriocapillaries. And as I said before, is that any disease that causes, that affects or disturbs the retinal function at the level of the RPE, the Brooks membrane, or the choriocapillaries can lead to CNV and scarring. And what are the causes? Here they are. By and large, the AMD is the largest cause of CNV, but also degenerative myopia, which is present here. Inflammatory conditions can also give CNV. Trauma to the eye, choroidal ruptures, for instance, can lead to CNV. Angioid streaks, which are also breaks in Brooks membrane, can also lead to CNV. And sometimes you have idiopathic, where we look but we don't find anything. Probably they're viral or inflammatory, but we don't know. Tumors as well, and retinal telangiectasia, and in some cases even retinal dystrophies. How does a CNV present? And of course, these symptoms are going to occur only when the CNV is in the macula. They're not going to occur when the CNV is peripheral and can be identified incidentally. So metamorphopsia, people who start seeing things that are crooked, that are no longer very straight, possibly a central scotoma, which can be described as dark or grayish, or just not seeing very well centrally, and really any sudden non-specific change in central vision. And when patients call and they say, I have this and this is something that requires your proper attention and immediate attention. This requires prompt examination, because CNV, if it's left untreated, it causes more scarring, and you want to limit the scar as much as possible. So if patients come in and they have these disturbances of vision, they really should be examined promptly. What are the signs of CNV? You can have a combination of so many things. You can have subretinal blood, as it's shown here. You can have a little bit of subretinal lipid. You can have subretinal fluid. Sometimes you don't see the blood, but you see the fluid, and sometimes just a little bit of lipid, which attracts your attention. So any of these things can occur. You can sometimes see a greenish or a grayish ring of CNV, grayish, that will show on an OCT or show on a fluorescein, but all what you see is some grayishness under the retina. And of course, subretinal blood, which can be minimal or a lot, okay? So, and you can also sometimes, particularly in cases of chronic CNVs, you can have cystoid macular edema, because the retina is really getting tired of all that exudation, and therefore some of the fluid pools inside the nerve fiber layer, the fiber layer of Henle, and you get the cystoid pattern of CME. And of course, subretinal lipid. You can also have sometimes pigment epithelial detachments. I don't know if it's very clear here, but here, for instance, this is a big PED in addition to lots of drusen. And sometimes when the process has been going on for a few weeks, you can start to see fibrosis under the retina, as is predicted here. I just want you to remember one thing. For me, subretinal blood is a choroidal neovascularization until proven otherwise. Now, it can occur because of trauma, because of other things, but the most common and the fearful thing that we fear is the CNV that is missed. So for you, what you need to remember is subretinal blood is CNV until proven otherwise. And vitreous hemorrhage is what until proven otherwise? Sorry? No. Break. Okay, diabetic retinopathy, you have a few days, to decide to treat. A break in the retina may go into retinal detachment. The patient loses his vision or her vision soon, okay? So vitreous hemorrhage is a retinal break until proven otherwise. Subretinal hemorrhage is a CNV until proven otherwise. Frame that, put it over your bed, look at it every day, you will remember. Okay. Differential diagnosis of subretinal blood. Of course, not all blood is CNV. So here it is. If you want to take a picture with your phone, that's fine with me. So retinal macroaneurysms can, of course, bleed inside the retina, in front of the retina, and behind the retina if the blood is thick. Lacquer cracks in myopia. We've seen a case today in which a young boy came in and with a dark area in the fovea that resulted from blood, due to a crack in the lacquer crack. So high myopic patients tend to do that. Of course, traumatic choroidal ruptures, of course, any trauma can lead to break. Subretinal blood, can happen even with PVD. Now, a PVD can give you pre-retinal blood or, vitreous hemorrhage, as we said. But if the blood is thick, some of that blood from traction can go also under the retina. So it has to be remembered. And of course, choroidal tumors. Now, any retinal vascular disease in which the intraretinal hemorrhage dissects under the retina can, of course, give you subretinal blood. So diabetic retinopathy, if you have, PDR, you can have subretinal blood. Usually it's pre-retinal, but if it dissects under it, of course, you can get subretinal blood. But just remember CNV until proven otherwise. And what is the differential diagnosis of subretinal fluid? Again, a very, very big list. All sorts of inflammations that can give you uveal effusions, can give you fluid, Harada's disease, posterior scleritis, choroiditis, but also CSCR, of course, as you know from last week's lecture, and of course all kinds of ocular choroidal tumors, okay, hemangiomas, nevi, and even metastasis. Now, if CNV is suspected, now the patient calls, has problems with central vision, you look, it seems like there's subretinal fluid or subretinal blood. Now you're suspecting CNV. What are you going to do? You're going to promptly investigate. How? You have 3 methods to investigate. We usually start with an OCT, but if you want something super, super definitive, it is a fluorescein angiogram. And if you have the technology that we have nowadays, OCTA, that is OCTA angiography, you may do that instead of a fluorescein. Now, a fluorescein angiogram, if you do it, you're going to have to do it, with proper technique, proper program. You start with an early phase, the transit phase, and then you do a mid phase and a late phase, because in the transit phase, that's when the CNV starts to fill, and in the late phase, that's where you expect to see leakage. Okay, so you need to see leakage to determine that this is a CNV, that this is no longer a scar that is staining. So the fluorescein angiogram is going to confirm the presence of a CNV, and because you see it in front of your eyes, you're going to see what type of CNV is it? Is it classic? Is it occult? We're going to go to this in a moment. Where is it located? Is it under the fovea, just next to the foveal center, which we call juxtafoveal, or is it away, called extrafoveal? And of course, it's going to determine the size. Nowadays, the size is not so important, but at the time when we didn't have anti-VEGF drugs, we used to treat with PDT, and for PDT, you need to determine the size. We're going to come to this in a moment. Most of the time, we just do an OCT, okay? Because the OCT will give you this additional information, will show you the CNV, whether it's under the retinal pigment epithelium or whether it has broken through the retinal pigment epithelium, and also give you the location of the CNV. and it will show you the additional features such as the fluid and so on. So it is it's also very useful when you are treating somebody with anti-VEGF, because it will tell you if your therapy is effective or not. And if you have an OCT angiography, okay, this is a non-invasive technique that does not show the leakage, but it will show you the skeletons of the vessels. So it will show you the vessels here, at the level of the choriocapillaris, usually at the level of the RPE, the outer retina. It will show you this elevation, and it will show you flow, inside this pigment epithelial detachment. So that's how you determine that there are vessels. There is vascular flow, but it will not show you leakage because they don't do that. Now, if you are hesitant, and FA is the standard and the classic way to really, confirm your diagnosis, and it does confirm it by showing the CNV here. You're seeing just a grayish membrane, perhaps just a tiny, speck of blood right there. And here you're seeing this CNV that is surrounded with a blocked fluorescence due to this hyperplastic RPE. And if you go on, this is actually an early phase. That's an early phase because you're in the laminar venous flow. So this is a transit phase, but if I leave this for a while, this is going to leak and you're going to have your diagnosis for you. Now, FA identifies the type of CNV, whether it's classic, occult, RAP, or polypoidal. Now, let's go through this a little bit so that it's understood. What is a type 1 CNV? Type 1 CNV is whether your choriocapillaries have grown from the choriocapillaris area under the RPE. The RPE is elevated and the growth happens here. Nothing has gone through the retina. This is why we call it type 1. It did not have the time yet to become type 2, going further, breaking through the RPE and going under the retina. And nowadays, we don't usually say choroidal neovascularization, but this is very, very recent. We usually call this macular neovascularization because it's more complicated than we think, subhanAllah. So you can also call it macular neovascularization type 1, okay? So this is what we call type 1 CNV or occult. Why is it occult? Because it's under the RPE. You don't see it clearly, okay? Now, if the vessels grow through the RPE and under the retina, that's when you have a type 2 CNV, which is a classic CNV, or a macular neovascularization type 2. These are usually more aggressive, okay? The retina really doesn't like anything under it. As long as the CNV is sequestrated here under the RPE, it's bad, but it may not be as bad as if you start having vessels growing just beneath the photoreceptor. That's pretty bad. So CNV is a classic CNV, and it's bad prognosis in general. Okay, now a type 3 CNV is what we call a RAP, retinal angiomatous proliferation. And in this case, the CNV doesn't originate from the choroid. What happens is the CNV actually originates from vessels of the retina which make their way down. And as they make their way down, the RPE creates some channels, for these vessels, and through these channels, the choriocapillaries start to join these retinal vessels, and you have a communication between the retinal and the subretinal or sub-RPE circulation, and those are pretty bad ones, and they're very difficult to get rid of. So this is a type 3 CNV RAP lesion, retinal angiomatous proliferation, or what we call macular neovascularization type 3. And a PCV is a specific type of occult neovascularization. The whole thing remains under the macula, under the RPE, but these are like branching vessels and that end with little polyps, okay? So you have aneurysms of the choriocapillaries, and these polyps, so this is why we call it polypoidal, because it looks like polyps. You have aneurysms, things look like, khuslat unab, so, and it stays under the RPE. And those are not so bad, but, they need treatment. So how does a classic CNV type 2 behave? Now, on a fluorescein angiogram, what you're going to see is essentially a network. Very early on, in the very early phases, you're going to see a network of vessels, lacy network, and in the late frames, you're going to see leakage. And in this case in particular, you also see the petaloid pattern of a CME that was associated with it. And here, in general, this classic CNV is pretty well demarcated. You can see the boundaries easily. You can detect the size easily. You can determine it. And what you have is you got progressive leakage beyond the boundaries. Here, for instance, you have a classic, a CNV that looks like a grayish membrane of CNV, and nasally you see the beautiful lacy net, but you can see the boundaries very clearly. And in the later phase of the angiogram, you see leakage, extensive, quite a lot of leakage. This is CNV, with no doubt. This is classic CNV. How does it look on an OCT? Well, the OCT translates the anatomy. We said from the beginning that the choroidal neovascularization grows through the RPE, under the RPE, and then through the RPE. So you expect to see an RPE elevation, and you expect to see also growth beneath, through the RPE. And if you look here carefully, you're going to see that this is the retinal pigment epithelial layer, okay? And if it was an occult, type 1 membrane, this RPE would be elevated, and all the growth will be under it. But what's happening here is that you've got a CNV that has gone through the retinal pigment epithelium, okay, under the retina. Here's the retina that is, elevated, and you've got subretinal fluid and some elongated photoreceptor outer segments. So it has gone through the RPE, and of course, because it's a reflective lesion, so what it does, it also causes, posterior shadowing. Here is the RPE. It is not detached. It's just vessels have grown through it. Okay, so this is pretty easily seen. You don't need to do a lot more. If you have this, you don't really need to do a fluorescein angiogram. You know that you're dealing with a CNV. But if you want to be absolutely sure, then FA is needed. What's an occult CNV? There are two types of occult CNVs. Both of them grow under the RPE. And we call them occult because we cannot see their boundaries very clearly. So either a fibrovascular PED, which is very common. Here is a classic membrane. Okay, this is classic, type 2. You have the net that you see early on in the angiogram, and here the net, as you can see, it has fuzzy edges. It becomes fuzzy and super hyperreflective. This is a classic portion of the CNV lesion, but the CNV also is not just here. The CNV is also extending. It is this whole area, and this whole area here you have basically speckled hyperfluorescence that's early on, but you really cannot see up to where it is. Where does it end? And about 1 minute to 1 minute and 1.5 minutes through the angiogram, then you start to see good leakage, significant leakage on it. So this is what we call a fibrovascular PED. This all what it means that the CNV has grown under the pigment epithelium, has stayed there, and it is fibrovascular. Of course, it has vessels, of course, but it's starting to lay down fibrosis under it. Okay, so this is a fibrovascular PED. This is an occult CNV. But there's also another type of CNV, which is what we call a late leakage of undetermined source. This is a fluorescein definition, okay? So here you have a speckled hyperfluorescence, which you really cannot see very clearly, and you cannot determine the source of the leakage. These are usually, pretty big. Here, for instance, you have the classic CNV portion of the CNV lesion. Here it is, early hyperfluorescence with late leakage. But then here, you see that the background isn't really normal. It isn't like here, for instance. You have unusual hyperfluorescence. You don't know where it starts, when it finishes, and towards the end of the angiogram, you see this leakage. So this is late leakage of undetermined source. It is also an occult CNV. How does a fibrovascular PED look like on an OCT? I'm making too much noise, I apologize. So as I said, it is basically an elevation of the RPE. This is the RPE, this is the Brooks membrane right there. It looks like a fine white hair, okay? And then here you've got the RPE. It starts to become corrugated, and whoop, there we go, okay? And it elevates, okay? Here, this could be another portion of the RPE, and you have all this layered fibrosis and membrane, very dense hyperreflective lesion under the RPE. If you follow the outer retina, this is the ellipsoid zone, you follow it and you find that it elevates really nicely, and it stays, not connected with the RPE. The whole problem happens between, the whole growth happens between the, the outer surface of the RPE and the Brooks membrane. Okay, so this is an occult membrane, fibrovascular PED. Now, this is another one. This is one of my cases here. This is a patient who has had a very long history of choroidal neovascularization. He has primarily an occult CNV. He's got pigmentation because this is a chronic lesion, and he's got, blood, a little bit of subretinal lipid, as you can see. And on the fluorescein angiogram, the whole thing leaks. I'm not really quite sure whether he has some occult, late leakage of undetermined source here, yes or no. It's possible. When you look at the OCT shows that this is an occult membrane very clearly. Again, this is the retinal pigment epithelial Brooks membrane. You follow the RPE, you find that it actually goes up and up and then down and up again, and here it becomes here multi-layered. This is hyperreflective. It is not serous. It is not clear. It is hyperreflective, so there is something, you know, growing in there, okay? And then if you follow the retina, the ellipsoid zone is up here, and then it goes up here, leaving you with subretinal fluid, of which is, you know, hyperreflective. So this is subretinal hyperreflective fluid, SHREM. And here you have, you know, the drusenoid PED, pigment epithelial detachment, and here you have clear subretinal fluid here, and actually, you know, fluid that is hyperreflective here. And you also have, because of the chronicity, CME, you know, with some fluid inside the retina. So this is, again, an occult type 1 AMD. How does a wrap look? A wrap looks usually like a pigment epithelial detachment with CME on top of it. This is the classic you know, way, and clinically you often have a tiny dot of hemorrhage. You have basically early fluorescence, okay, and then you have progressive leakage, like all CNVs. It leaks, but what you know, characterizes it, often you have a retinal hemorrhage. You can see a retinal and not just a subretinal hemorrhage. And a PED is almost always there, and a CME is also very classic. Now here's another case of mine. This is a huge wrap lesion, okay? There is a pigment epithelial detachment right there. There's subretinal fluid. There's huge CME and subretinal fluid. So that's a wrap lesion. How does a polypoidal lesion look like? Well, clinically, you can have a retinal and subretinal fluid. You can have subretinal lipid. It's often accompanied with lipid and subretinal blood. And then here, if you do an ICG, you can see the polyps, basically, tiny little growth right there. And if you do the OCT, which is fantastic, actually, so to show polypoidal vasculopathy, you will see the polyps, and they're at the undersurface of the RPE. Here's the Brooks membrane bending down, and here's the RPE going up, okay? And under the surface of the RPE, you see the polyps. And here's subretinal fluid. So this is a polypoidal vasculopathy. Here's another one that was taken from an article that was written by my colleagues, Dr. Gahtani and Dr. Ghazi. Here is the fluid. You have a lot of fluid right there. You have a subretinal lipid, perhaps a tiny speck of blood here, a tiny speck of blood here. And when you do the fluorescein angiogram in the late phases, of course, you're going to see the leakage. But if you do an ICG, which you don't need, but here this is just for demonstration. If you do an ICG and you have the line that goes through these hyperreflective polyps, okay, they're not reflective, I'm sorry, hyperfluorescent polyps on ICG, this is the line that corresponds to here, and you can see that the RPE is elevated. Sometimes it has an M-shaped or a QRS-shaped elevation, you know, going up and down like this, but tadaris, you know, and you have all these polyps here, you know, these round or oval structures at the undersurface of the RPE. Very, very characteristic. And the retina is intact, except that it has subretinal fluid. Okay, so FA will identify the type of CNV, we said, but it also identify the location. And what about location? You need to know these terms. I do not want to hear, you know, using the term juxtafoveal كده بس haphazardly ولا extrafoveal haphazardly. You have to know the definition. So an extrafoveal lesion is a CNV in which the edge, not the center, the edge of the CNV is 2,000 microns or 200 microns from the center of the FAZ. If this is the center of the FAZ, then an extrafoveal, okay, an FAZ, how big is the FAZ diameter? Sorry, say higher, please. I can't hear you, I'm sorry. 350, somebody said 350? Okay, 300 to 500. 300 to 500 is usually the, you know, the diameter of the FAZ. So if it's 350, let's say that's 350, so half of 350 is 175. So anything that is 200 microns, if you have a CNV right there, for instance, or here, and it's 200 microns from the center, it's called an extrafoveal, okay? A juxtafoveal CNV is a CNV that comes right until the center of the fovea. Anything that in which the edge comes within 1 micron, okay, definition. Of course, it's going to be very difficult to distinguish that, but that is a juxtafoveal CNV. If you have a CNV right here, I don't think anybody is going to say juxtafoveal. You're going to say extrafoveal. But right here, you're going to have to make a pretty good analysis to tell me whether this is juxtafoveal or extrafoveal based on these definitions. And a subfoveal CNV is when part of the CNV is under the smack center of the fovea. So if you have a CNV that is like this, okay, but in which the edge is down here, that's called an what? Sorry? Called what? You guys are sleeping? Shall I stop? Subfoveal. Okay? Okay, this is supposed to be an interactive lecture, and if I don't feel that there's interaction, I'm going to use my time better. Okay? So, if you have a part of the CNV that is under the center of the fovea, even if the CNV extends like this is not a juxtafoveal, this is a subfoveal. Is everybody clear on that? Okay, any part of the CNV that is under the smack center of the fovea is called a subfoveal CNV. So here it is. This is obviously an extrafoveal. This is so far from the CNV, from the center of the FAZ. This is the center of the FAZ, and obviously this is more than 200 microns. An optic nerve is how much? What's the diameter of the optic nerve? 1,500. I really appreciate if you raise your voice because I can't hear you very well. So obviously this area is, if you count from here to here, you have at least 500 microns. So this is an extrafoveal, it's not a juxtafoveal one, while here this is obviously a subfoveal CNV. Okay, once the diagnosis of CNV is confirmed, you're going to have to identify the associated condition and start treatment. What is the highest giver of CNV is AMD, age-related macular degeneration, which right now has a definition that's an alteration of the neurosensory retina and the RPE, as you know, the choroid, of course, as the eye matures, and it's the leading cause of blindness for people over 50. There are risk factors that are known, obesity and genetic factors are definitely known. Age is, of course, it is an age-related macular degeneration. You cannot really make the diagnosis of age-related macular degeneration for somebody who just has drusen but is 35 years old. That's not, AMD. Okay, cigarette smoking, obesity, and low level of dietary antioxidants may also contribute. Now, as per the international classification of AMD, early AMD is characterized by or defined by the presence of just soft drusen and RPE changes. But late AMD is defined by the complications or the consequences of these drusen and RPE changes, meaning you can have geographic atrophy, okay, such as we have here, or you can have neovessels, CNV, which is what we're talking about, either frank choroidal neovascularization or really large pigment epithelial detachment, and of course the scarring, which is the end result. Drusen are the markers of AMD. You cannot have AMD without drusen. At least this is what the science tells us now, okay? And these are focal, retinal pigment epithelium, but mostly subretinal pigment epithelial deposits. They're mostly in the macula. They can have small hard drusen, as we see here, and you can have larger drusen. And the larger the druse, the higher the risk for CNV. So yeah, that's what I was saying, is that if you have large drusen, such as this one here, for instance, or these confluent, greasy, fatty drusen, any druse that is more than 63 microns in diameter has a higher risk of CNV. Pigmentary changes and relative hyperfluorescence also are signs that predict a higher possibility of getting choroidal neovascularization in the future. Also pseudodrusen, but reticular pseudodrusen, which are subretinal drusenoid deposits, these are also associated with higher risk for developing CNV. Now, but I'm not going to talk about that now. This comes to another lecture. So AMD, geographic atrophy, about 10% of people who have late AMD tend to have geographic atrophy, and this is a progressive atrophy for which currently there is no treatment. There is one single drug right now that may have FDA approval that may slow the progression of geographic atrophy, but until now, patients who did not develop CNV but continue to have progressive atrophy of their outer retina and their retinal pigment epithelium had no hope. They could only use magnifiers to see well. So it starts usually with pigmentary changes, and then you can have like little atrophic areas, and these atrophic areas all come together, and they start to give a massive atrophy of the retinal pigment epithelium and the outer retina, which is what we call complete retinal pigment epithelium and RPE atrophy, which we call C-RORA. This is the proper term now. And if you do a fluorescein, an OCT, what you're going to see is the absence of the outer retina. You can see a very thin RPE and, of course, posterior shadowing. So this resembles, of course, central areolar sclerosis. It resembles some dystrophies, but of course, when you have, an older patient with the drusen, the diagnosis is not so difficult to make. Autofluorescence is a fantastic way to determine the size of the geographic atrophy. This is the same patient, but here you can't really determine the size very, very easily. But on autofluorescence, you will have an absence of fluorescence because there is no RPE and there are no photoreceptors to give lipofuscin or any radiating materials. CNV, about 10% of patients will have choroidal neovascularization, which is the subject of our talk today, but these are the causes for the massive and the most common visual loss. As I said, it could be occult or classic, which I think you know by now. And they are frequently large and frequently subfoveal. Here's one of my patients who started out like this, and then ended up with a huge scar. This is the same patient. It started out like here you can see this artery here, the vein. Sorry, here it is. So it's the same patient. Started out with this tiny CNV, and look how much it grew despite treatment. Okay, but this was a treatment at the time when we did PDT, not anti-VEGF. Other features of neovascular CNV is the serous pigment epithelial detachment, which you have CNV leaking fluid under the RPE. CNV is leaking blood under the RPE, which we call hemorrhagic PEDs, and drusenoid PEDs, which is when you have really large drusen that come in a confluency. They don't necessarily give you a CNV, but at any time these things can burst, and you can even get RPE tears. The natural history, we've talked about this, that it's quite bad, especially for untreated lesions. This is why you have to rush to treat CNVs with anti-VEGF and treat them properly and on a monthly basis and follow them closely. As I said in the beginning, that classic CNVs have a worse outcome than occult CNVs, but all of them are not really nice to have. Please take a photo of this. So I don't have, this is like a classification so that you have, when you use the proper terminology, you will say this AMD stage 1, stage 2, stage 3 or 4. These are the stages, okay? So, okay, I suppose you have it. All right. Now, what is the other cause of CNV? As we said, degenerative myopia. It's also a leading cause of blindness, particularly in the East, but also nowadays, the Middle East also has a lot of people who are myopes. The classic definition is a myopia of more than 6 diopters and an axial length of more than 26. And what you get is a progressive choroidal thinning, RPE thinning, retinal stretching, all these things that can lead to a disturbance of the RPE layer and to cracks in the fundus. Now, what are the features of myopic fundus? Well, the myopic conus, meaning this peripapillary atrophy that you see here, that looks like a cone, a staphyloma. Now, this is not a staphyloma, guys. A lot of people tell me, "Oh, staphyloma." That is not a staphyloma. What a staphyloma is, a posterior staphyloma, is an outer bulge of the scleral wall. Okay, so basically, the sclera is not regular. The sclera, it kind of has these bulges, like when you boil an egg and it cracks while you're boiling it, and you have all that white that comes out of it, and you've got an egg that has some white coming out of it like this, that is condensed protein. That's how a staphyloma looks, and it can be in the macula, it can be nasal, it can be all over, it can be inferior to the disc, but that's what a staphyloma is. You best see it when you do an indirect ophthalmoscopy, because that's when you appreciate the stereopsis and you see that the eye is bulging backwards, okay? RPE and choroidal thinning, of course, I think you all know that. Atrophic areas, such as here, usually what happens, you have atrophies, the RPE stretches, you get breaks in Bruch's membrane, and these become larger and larger breaks, and they look white. So these are what we call the geographic atrophies in myopia. You also have lacquer cracks, which are cracks in the Bruch's membrane that can lead to hemorrhages or ingrowth of choroidal neovascularization from it, macular hemorrhages, and finally a Fuchs spot, which is the end stage of a CNV. Here's a lacquer crack. Here's a patient of mine who basically has a CNV on top of a lacquer crack. Now, a lacquer crack, usually it's hypopigmented. Sometimes it is pigmented, but in general, it's hypopigmented. Okay, these are linear cracks in the Bruch's membrane. They can be horizontal, they can be multiple, they can be arcuate. All shapes, all length, all distances, all thicknesses are possible, and usually they are the origin of a CNV. Here's a grayish CNV lesion. Okay, if you get a CNV, here it is, this is the same picture, you get a classic CNV. Here's the lac crack in the early phases of the angiogram. We are in the early venous phase. And here in the late phase, you can tell that it's a late phase because the large choroidal vessels are now hypofluorescent. Okay, so the choroidal background has dimmed and the choroidal vessels are emptying themselves. And what you're seeing here is the lacy pattern of the classic CNV. And here it is in the late phases. It really leaks massively and brightly. This is a classic CNV in myopia. In general, the closer the lac crack to the center of the fovea, the worse the prognosis is. Clinically, you only see a grayish lesion. You may not see it at all, actually, because the choroid is so thin. Okay, and in general, these CNVs become symptomatic when they're close to the fovea, and in general, they are not as extensive as the ones that you see in AMD. Okay, so the lesion tends to be small. You don't have much hemorrhage, very little, and hardly any lipid, but a little bit of fluid on the OCT. Okay, so that's how you make a diagnosis. Here's another one. This is another patient. Here's the myopic fundus with the conus, with the atrophies, and here are some lac cracks. Now they're more visible on a fluorescein angiogram. Here's a lac crack. Here's another one. Here's another one. Here's another one. And now you have a CNV. And here's another one. Okay, all of these are lac cracks, right there. Okay, and on the late phase of the angiogram, you can see that this area leaks. Okay, now the pigmented area where there is a little bit of blood stays blocked because of block fluorescence, but the lesion, the CNV lesion, just under it leaks profusely, and this patient, will, of course, would require treatment. In general, the natural history of CNVs and myopia is not as bad. They don't need so many anti-VEGF. Sometimes 1 or 2 injections will do, but not always, so you still have to follow. And in general, people who get this will tend to have some kind of a small scotoma centrally. Angioid streaks is also a very common cause for choroidal neovascularization. Again, these are just like lac cracks. These are breaks in Brooks membrane. Here they are. Here you can see the angioid streaks right there. Okay, there's one right there. There's another one here, and they are here on the fluorescein angiogram, very easily detected. And here is the CNV. Now, angioid streaks need to have a treatment and need to have good follow-up, just like AMD. Their CNVs tend to be aggressive, and you need to continue to monitor after you've treated them and you thought, halas, everything is fine, the CNV is no longer active. Well, you'll be surprised. The patient comes in 6 months later or a year later and the CNV is active, because they tend to develop this all the time. Be careful also with scleral depression. You don't want to depress too much so that you don't create more breaks in their calcified and brittle Brooks membrane. People who have angioid streaks need to be also evaluated for systemic problems that may be associated with angioid streaks, such as you know, pseudoxanthoma elasticum and Paget's disease of the bone and sickle cell anemia. In general, if they are not treated well, the prognosis is not so good. Okay, so visual prognosis. Traumatic choroidal ruptures, again, you have a rupture in the Brooks membrane, but this time it's traumatic. Again, these ruptures can be arcuate, can be horizontal, can be nasal. Usually they're arcuate, and they're usually in the papillomacular bundle. And the longer the choroidal rupture is, and the closer it is to the fovea, the more the risk of developing CNV. Here's a choroidal rupture, and here is a tiny CNV right there, okay, with a little bit of blood that blocks the fluorescein right over there. Okay, those also need to be treated with anti-VEGF. Idiopathic, as I said before, is when we look for a cause and we don't find them. We think these are inflammatory. They usually happen in younger people. They're usually classic, okay? They have early hyperfluorescence and late leakage. And then, of course, there is also the possibility of getting, juxtapapillary CNVs, which, can you hear me like this if I take this off? Yes? Okay, maybe I should take them off because it's making too much noise. Can you hear me? Okay, good. All right, so juxtapapillary CNVs can happen every time that you have an enlargement of the optic disc, whether it's inflammatory or a pseudotumor cerebri. You've got, papilledema. The optic nerve head enlarges and it causes cracking of the Brooks membrane around it, and then you can have CNV right next to it. Okay, now, how do you treat a CNV? Well, Right now, there is no treatment that can prevent it, nor that can completely eradicate it fully. So basically what we do is we temporize, we try to minimize the consequences of the CNV by keeping it small, by trying to involute it, giving it time to involute at a small stage where it's still small, rather than when it's big and has caused so much fibrosis. Okay, so I'm not going to go through through the lengthy strategies to treat CNVs. You can tell from all these possible treatments, and that I even took off laser because we have tried for the past 50 years to figure out how to eradicate and treat CNV. And at one point, laser ablation was the possibility, the only possibility. And then when PDT came, everybody was clapping because nobody wanted to burn and destroy the retina close to the fovea or even at the fovea. And then when anti-VEGF came, we clapped even harder because the reasons, the results were so much better than PDT. But you can see that also there were so many attempts in between before we found anti-VEGF to do something about it, and that is, by doing a feeder vessel therapy with laser, by removing the CNV, doing surgery and extracting the CNV, or even by cutting off the retina and tilting it so that the fovea stays away from the CNV. Tremendous, tremendous things. Let's talk about the most important one that we, that is now accepted as the treatment for CNV, and that is to cause it to involute, and that's the anti-angiogenic treatment for CNV. This is the current treatment of choice, and it means to inhibit VEGF, as we said earlier, that CNVs grow because of a balance between VEGF, which is an angiogenic factor, and the anti-angiogenic factor. So if we inhibit the VEGF, we cause involution of the CNV. The anti-VEGF work by two mechanisms. They first cause the vessels to involute, but they also decrease the permeability, so it helps in reabsorbing the fluid. Now, what are the anti-VEGF treatments that we know? Well, the first one was Macugen, pegaptomib sodium. This inhibited selective type of VEGF. It is not as effective, and we don't use it anymore these days. And what we use now is these first three, and perhaps one day even the last one, this Beovu brolucizumab, which has a longer duration of action, but and dries the retina really nicely, but it has a lot of complications, unpredictable vasculitis and vascular occlusions in the retina, that make people very afraid to use it. So the treatments are mostly Lucentis, which is the first anti-VEGF that was studied in clinical trials and in practice. It's called ranibizumab, and the original name was Rufab. So if you ever hear Rufab, that's the same thing as Lucentis. Avastin, which is bevacizumab, which you all know and which you use, which is not indicated for choroidal neovascularization. It's actually for cancers in the body, but it happens that it works and it's much cheaper, so most people in the world use it. And Eylea, which is aflibercept or VEGF trap eye. Here is if you want to take a moment to take a picture of this, so that we don't have to go through this and you can study this on your own. Forget the. Oops, sorry. I am so sorry. We'll go back. Forget this one. This did not get approval, okay, by FDA. All right, this was promising, but it did not get approval because of lots of inflammation. So what we have here is the bevacizumab with the Avastin, the Lucentis, the Eylea, the Combercept, which is like Eylea but made in China, okay. I don't know if one day we will use it. It's called a biosimilar. It's similar to Eylea. And then the brolucizumab, which is the new kid on the block. Okay? So Lucentis, it's basically an antibody fragment that inhibits VEGF. It's a very, very tiny molecule. It penetrates all retinal layers, and it inactivates all forms of VEGF. Okay? And what you need, as with all these injections, you need multiple injections. You need monthly injections until the pathology is stable. And in some cases, you may need to continue for a very, very long time, years with monthly injections, or in sometimes, 2 months if you're using Eylea. Okay, so you get a stabilization of the CNV. You don't get an eradication of the CNV. If you stop treating, it grows again. So, the burden on the patient, but also on the doctor, is tremendous. Okay, and it is expensive. Now, I don't have time to tell you about all these trials, but I have a handout. I will give it to the secretaries, and you can read about these trials in a summarized way. But you need to know few names, and those names are the Anchor and the Marina trials, which were the first ranibizumab trials in AMD. which set the stage that, yes, this is how we treat CNV now in this 21st century, and the CAT trial, which was a head-to-head comparison between Avastin and Lucentis, because people were wondering for a long time which drug is better, which is safer, and the CAT trial is a hugely important trial for you to know. So what the results of these trials showed that anti-VEGF did prevent major visual loss in the majority of patients, and it yielded also significant gains. Before that, PDT did not allow patients to gain vision, but it allowed to kind of stabilize their vision, and not always. But with anti-VEGF, you got the ability for patients for the first time to actually have better vision. But you need rigorous monthly monitoring and dosing. Here's some conclusions that are important from these ranibizumab trials. The PEER study. In the PEER study, the patients received 3 monthly injections, okay, one injection every month, and then after that, it was on a PRN basis. And of course, the vision one was better than no treatment. Sham was no treatment, okay? But of course, not as good as the ANCHOR and the MARINA studies in which patients received regular, not PRN dosing. The SAILOR and the SUSTAIN studies basically showed that after 3 monthly injections, you get a rapid visual gain, but the gains decreased with time, especially when you start to have a follow-up of PRN, 2 years later. The EXCITE study basically showed that the monthly treatment provided the highest visual acuity gain compared to every 3 months treatment. People were trying all kinds of combinations. And the HORIZON study is that what it showed, this is a HORIZON, this is something that went really long, like for 5 years, and it showed that even if you treat those patients regularly and well, by 5 years, the vision tends to drop. Of course, much better than no treatment, but the AMD has a tendency to lose, for people to lose their vision slowly down the line. It's almost inevitable, للأسف. Avastin. Avastin is a monoclonal antibody which inactivates all isoforms of VEGF. As I said, it's used for colorectal cancer, and for CNV, it's used off-label. Okay, the label on the drug does not allow you to use it inside the eye. The dose, which you need to know, is 1.25 milligram, and you give it the same as Lucentis. You give it like every 4 weeks, and it causes also improvement of vision. And it lasts longer than ranibizumab inside the eye, but also inside the body. And this is why it could be a little bit dangerous for people who have myocardial infarctions, or even for children and premature babies, because the half-life is longer. It lasts longer in the body. And the CAT study is the head-to-head trial of Avastin via Lucentis. Here's the design. So people were randomized equally. Some people received, half of the patients received Avastin, half of the patients received ranibizumab, and in those half and half of the patients received monthly, and half received 3 monthly, followed by PRN. And they were compared head to head. And what it showed is that basically both of them have equivalent effects on visual acuity if they are given according to the same schedule. Okay, and the best vision results were when the treatment was given monthly, and the ranibizumab caused more reduction, more drying, of the thickness, more drying of the fluid, and more reduction in the fluid. Basically, a monthly evaluation with the PRN and ranibizumab basically gave the same visual outcomes as monthly ranibizumab. That means you don't have to treat every month. In this protocol, they didn't have to treat every month, but they had to be seen every month. And if they were dry, they were given, okay, they were seen next month, which means that the treatment burden really wasn't any less. Okay, you still had to see the patient. But in general, it showed that the Avastin was not so inferior to Lucentis, which is good. Okay. Now, Eylea is the one that we mostly use here. If we feel that Avastin is not working very well, it's a very potent drug because it inhibits both the VEGF-A, but also the placental growth factor, which is a little bit of an inflammatory product. So it acts in both ways. It's called it traps the VEGF inside the molecule, and therefore it has a strong effect. The studies that, what am I doing? No, I'm doing something wrong here. Yeah. Okay, so the VIEW studies are the ones that evaluated the effect of aflibercept compared to ranibizumab in AMD, and found that actually after 3 monthly injections, aflibercept given on a 2 months interval did just as good. It was not inferior to ranibizumab given every month, which, of course, much better for the patients, much better for us doctors. It decreases the burden. Okay, so that's all what you need to do to know about this. So, in general, with all the anti-VEGF treatment summary, is that the anti-VEGF are the mainstay of treatment. They inhibit proliferation, they inhibit leakage, they are effective almost 100% in maintaining the condition, and there's a 40% chance of improvement, but you need continuous treatment and continuous monitoring, and you get a rebound effect if you lose treatment. Okay, there are risks. Nothing is without a risk. They cause hypertension, so beware. If people are hypertensive, they may, after the injection, actually get a spike of hypertension, so be careful. There is a possibility that they increase the thromboembolic effects, and therefore, cerebrovascular accidents and myocardial infarctions. And of course, locally, as with every injection, you can have hemorrhages, you can have related complications due to the injection itself. Intraocular pressure may rise, and of course, always the possibility of endophthalmitis, never forget that. And patients who use a lot of it, anti-VEGF may create a little bit more atrophy, because VEGF is important for the health of the retina. And if you inhibit it all the time, then the retina suffers. Okay, now what is new? Because you need to know about the new stuff. The new stuff is that there's something going into the FDA approval, and that is drugs that have longer duration. Besides the brolucizumab, which is FDA approved but which has complications, there's something called faricimab, and this is a biospecific antibody that targets both the angiopoietin 2, okay, right there, and the anti-VEGF. So it seems to be more potent, and it seems like people can stay up to 4 months in between injections. So let's hope. And there's also the reservoir, which is a surgically implanted little dizzle here. It looks like this. You implant it at the level of the pars plana. It is filled with Lucentis, and then you get to fill it every 6 months. You cover it just like you cover glaucoma surgery. Dr. Abidan is right here. And what happened in the beginning is that there were lots of hemorrhages that were, vitreous hemorrhages that were associated with this, but now the technique is a little bit better. But of course, you're covering it with conj, and every 6 months you're going to invade the conj, and you're going to inject this reservoir and fill it with the Lucentis so that it leaves shwaya the Lucentis into the vitreous. The problem is that I suspect that with time, you're going to get fibrosis, and you may get encapsulations, and you may even get bleb-related endophthalmitis one day. Who knows? So, to be monitored. I'm just going to go very quickly about the other treatment strategies so that you have an idea, of what can be done to CNV if you don't have anti-VEGF, and that is photodynamic therapy. Photodynamic therapy is basically infusion of a drug called Visudyne into the venous circulation of the body. This goes throughout the whole body, and then you expose a specific diode laser, on the eye, on the area of the CNV. What it does is that the dye itself causes release of oxygen-free radicals. This will damage the vessel wall of the CNV, and it will cause the CNV to thrombose, okay? But then with time, within 3 months, the CNV actually opens, and then you have to do it again. So it's every 3 months treatment. And it does not improve vision, okay? And it may even cause choroidal atrophy. So actually, nowadays, we don't use it for treatment of CNV. However, when the anti-VEGF is not enough, we may add it as an adjunct to the anti-VEGF treatment, particularly in cases of, polypoidal vasculopathies or RAP lesions, because sometimes they're more difficult to eradicate. Okay, what we do is we infuse the dye for 10 minutes, and then 5 minutes after the end of the infusion, we expose the eye with this light. Okay, and these are the parameters. You don't need to know that, just know the principle of it. Okay, so you get a temporary CNV closure, but you have to repeat it every 3 months, and there's no improvement in vision. And of course, there may be complications, RPE damage, visual loss, as I said, choroidal atrophy, and in some older patients, they can get back pain during the infusion. We don't know exactly the cause for that, or at least I don't know what it is. What are the indications for PDT in CNV? Is that in polypoidal and in RAP, okay, so as an adjunctive treatment. You can use If you're very good and if you have good ICG and good ICG films, you can monitor the entrance of the blood from this specific 1 or 2 or 3 choroidal vessels that create the network of CNV, and you can target the feeder vessels with laser to occlude the feeder vessels. This was used at one time by Professor Storenji, but also by some others. It can get you the CNV to shrink, but as you know, what happens, especially in AMD, new vessels start to sprout, so it's like you're chasing it's a cat and mouse chase, basically. People have stopped doing it because it's not really very effective, and anti-VEGF is so much easier to use. And it also acts on the overall background of the RPE, not just on the specific target of the CNV. You can also remove it, and this is good in some cases, in inflammatory CNVs that are growing on top of the RPE. But it's not good for AMD, and it's not good for any occult CNV, because when you remove it, you actually remove the RPE with it. So you create actually damage. But how it is done is you do a vitrectomy, and you peel off the hyaloid, okay? And then after that, you basically do a small retinotomy with a 41 gauge needle, and you start to infuse BSS to create a bleb, okay? And then you get with your scissors or your forceps, you go under the RPE, and you basically extract the CNV from under the RPE, and most of the time you extract RPE with it. So we don't usually use this much. Of course, the patient gets air fluid exchange and remains prone for a few days.